Now let's discuss the bipolar spectrum. Mood disorders not well described by the above categories previously would have fallen into not otherwise specified or NOS, but now such patients are seen as belonging in general to the bipolar spectrum, and in particular to one of several additional descriptive categories that have been proposed by experts such as Hagop Akiskal. The first one being bipolar 1/4 or 0.25. This is an unstable form of unipolar depression that responds sometimes rapidly but in an unsustainable manner to antidepressants, the latter sometimes called antidepressant pop-out. They have unstable mood but not a formal bipolar disorder, yet can be benefited from mood stabilizing treatments added to robust antidepressant treatments. Coming on to bipolar half or 0.5 and schizoaffective disorders, sometimes also known as schizobipolar disorder. Experts have debated whether psychotic disorders such as schizophrenia, as Kraepelin has proposed, with chronic unremitting illness with poor outcome and decline in function, are dichotomous from mood disorders, usually cyclical illnesses with better outcome and good restoration of function between episodes, or are part of a continuous disease spectrum from mood to psychosis. Proponents of the dichotomous model point out that treatments for schiz differ from those of bipolar disorder, since lithium is rarely helpful and anticonvulsant mood stabilizers have limited efficacy in psychotic symptoms, perhaps only as augmenting agents. On the other hand, the continuum disease model proposes that psychotic and mood disorders are both manifestations of one complex set of disorders that is expressed across the spectrum, with schizophrenia at one end and at the other end bipolar disorder, with schizoaffective disorder being in the middle. Now, modern genomics suggests that spectrum is not a single disease, but a complex of hundreds, if not thousands of different diseases with overlapping genetics, epigenetics, and biomarkers, as well as overlapping clinical symptoms and functional outcomes. Proponents of this claim, treatments of schiz overlap greatly now with those of bipolar disorder, since second-generation atypical antipsychotics are effective in positive symptoms of schiz, as well as in psychotic mania and psychotic depression. These are also effective in non-psychotic mania as well as bipolar and unipolar depression, and seem to be effective in the spectrum of symptoms for schizoaffective disorders. And interestingly, failure to give mood-stabilizing medication may lead to suboptimal symptom relief in patients with psychosis, as prominent or eye-catching psychotic symptoms mask or distract clinicians from seeing underlying and perhaps more subtle mood symptoms.